Well, hello and welcome to the 27th Degree with Chris and Nancy. So today we'll be discussing cardiac health with Dr. Juan Mendieta. And before we begin our conversation, I'd like to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And as always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook, Instagram. Also, please remember to leave a review, and 5-star reviews are always greatly appreciated. So great to have you here today.
Thank you.
We've had a couple. Oh, you're welcome. We've had a couple cardiology podcasts, and they've been more directed at interventional cardiology and that. So I really wanted to talk about non-interventional cardiology because it's so important. It's really most of what I deal with, in my practice and that. So first of all, can you tell us a little bit about yourself?
Yeah, sure. So Juan Mendieta, I am from Dominican Republic. Came in 2010. I did internal medicine at St. Elizabeth Medical Center. And then I worked as a hospitalist for 2 years before going into cardiology at Bay State in Western Mass.
Sure.
And then since then, I moved back to the Eastern Mass area, came to primary care, and I have been here since 2018.
That's great.
My wife is here with me in Stoughton. We live in Stoughton, and we have a daughter of 7 years. My wife is a teacher at the same school that my daughter is at.
Oh, that's
so
nice.
It makes it very easy and very welcoming in this area.
Nice. Excellent. It's been great to have you down here.
Thank you.
Patients have really enjoyed seeing you, and they've really benefited.
Yeah, this population here, I must say, that is really, really thankful for everything we do for them.
Yeah.
So it's rewarding to see that the families really appreciate what we do for them, and that kind of pushes you towards getting better with each day.
Yeah, definitely. It's a great population to practice with. So you're in your area of cardiology, you're doing mostly like non-invasive type of cardiology.
Yes, we do non-invasive cardiology, and that means that we cover most of the aspects from cardiology, but we don't do any interventions.
Okay.
One of the big one is one of the things that we're here for is the preventive cardiology. At the same time, we also read echocardiograms, nuclear cardiology, stress tests, cardiac CTs, heart failure a little bit, and also in the hospital we round with our colleagues and our MPs. But that's basically our focus in that area.
So inpatient and outpatient and
inpatient and
non-invasive, non-interventional, I should say, cardiology. So let's just start really basically in a basic fashion. When should someone see a cardiologist?
As you know, as internal medicine, what we like is to take care of the basic stuff in medicine. By stuff in cardiology, I mean hypertension, arrhythmias. But a patient should be seen by a cardiologist whenever something is out of proportion. And I'm going to define that a little bit more. Well, you have a patient, 40 years old, that suddenly has some chest pain. It sounds more like a heartburn. You start treatment, it doesn't get better. And now the patient says, "Doc, he's been getting worse." But that's a red flag. That's the time where the cardiology gets involved, because we were talking earlier before the show started. Unfortunately, nowadays the symptoms are no longer as classic as before. They overlap a lot with other things.
Right.
But you know what? A bad heartburn will not kill you, but a heart attack will.
Right.
So it is important to rule that out and then continue with further evaluations. In the terms of blood pressure, you have a patient that comes to your office, hypertensive, was found incidentally, as many hypertensive patients do.
Right.
You start a treatment, it doesn't get better. So what's going on? So maybe there's renovascular disease, maybe there is Crohn's disease, maybe there's something, another component like pheochromocytoma, things like that. So that's when a cardiology gets into place.
Yeah, and just to back up for the audience so they understand, so most of the hypertension issues or high blood pressure issues we see are not related to a secondary cause that we can define, and that's probably, I'd say, 98 or more percent.
What does that mean?
So it used to be called essential hypertension. It was probably a bad term, and now it's called more primary hypertension, meaning that it may be related to factors such as aging, stiffness of the vasculature, things that aren't secondary to an other medical issue, like the doc had mentioned, renal vascular disease. So, basically a stricture in the renal arteries where there's decreased blood flow to the kidneys. And with that, the kidneys produce secondary chemicals that cause, it produces high blood pressure as a result of that because they're starved for blood flow.
So it's kind of unexpected. You're like, whoa.
It is, like Dr. Juncker says, it is rare, but any resistant hypertension a cardiologist or even a nephrologist, just so you know. I mean, hypertension is not only a cardiac field, other fields get in the way as well, and they can be very helpful.
Right.
So definitely at that point, we should get the expert's opinion on that.
When is blood pressure like too high? Like what kind of readings are we talking about?
Happy to go over that. So in the JNC8, there's been some debate, but I think at this point we're very clear that optimal blood pressure is anything less than 120 systolic and less than 80 diastolic. Now, as we age, unfortunately, things are not easier to keep there.
Right.
But we do have an area.
You're not far behind me.
I'm ahead of you.
Well, going back. So basically, the pre-hypertension, vast of our patients are there, which is the 121 to 139 systolic and 81 to 90 diastolic. So this is the time, this is the importance of having continuous checkups.
Right.
Because once you identify this is actually reversible. We can make long-lasting changes there. Now, once hypertension is established, it's defined as grade 1 when it's 140, above 140 to 160 systolic, and also 90 diastolic from 90 to 100.
Okay.
Then severe, or grade 2, it's going to be more than 160 and more than 110 in the diastolic part. And those are things that, as I said, if you identify them at the beginning,
right,
that's the vast majority of the interventions will work long-lasting there.
So what is the danger? Like, what does high blood pressure do to your body?
Untreated, left untreated, it can, I've seen patients with blood pressure in the 200s, 230, and you can stroke with that. Okay. The more pressure you have, if you think about it, the blood pressure is not something cardiac. It's actually the result of the resistance of your body to the blood flow that affects your heart.
Okay.
So your heart starts to grow, and you can develop heart failure, particularly preserved ejection fraction, which means that your heart function is stable, but you're no longer relaxing like it was supposed to. So if you think about it, the heart is like a little house. Right. I always tell this to the patients. So if you think about it, there's 2 pumps.
Yeah.
There's electricity. Yeah. There's plumbing. There are doors, and there are chambers. Virtually every aspect of a house.
Right.
But when the heart pumps, when it contracts, it gets the blood out to the periphery. That's one function. But something that we have not discussed much in the periphery is that the heart needs to relax, needs to create a negative vacuum to bring the blood from the lungs that are already oxygenated to the rest of the body. Okay. So heart failure with preserved ejection fraction is a well-known entity that affects a lot of people and has equal mortality than weak hearts. So many people say like, oh, my heart's function is normal.
Yeah.
Really normal? You have to check into that. And that's when the cardiologists get into play. So this is we're saying heart failure. The same heart failure and the stiffness of the heart can lead to arrhythmias. So everything in the heart is connected. Like you can have arrhythmias, you can have heart failure, you can have heart attacks as a result of all that. So blood pressure affects your kidneys too. And it's actually one of the major organs affected by blood pressure, particularly kidneys, brain, and heart.
Yeah. So when you have a primary care practitioner and you're going to them, I know you'll refer people to a cardiologist. Is it only like referral basis for you? Or if people are like, oh, my heart's doing some like weird things and maybe I don't have a primary care, can I just...
It depends on your insurance, right? Because, I mean, if most insurances other than Medicare probably require a referral unless you have a PPO or you have one of these plans where you can go wherever you want. But I'd say the majority of patients do require a referral. If you have straight Medicare, you don't need a referral. You can go. But I think it's always good to have a primary anyway, because, I mean, there's a lot of things that, a lot of times patients will come to me, and this is a bit of an aside, but they'll say, I want to go to this particular specialty. And then when you hear the story, like, it's not really where you want to go. You'd be better served going to a cardiologist rather than this doctor, or a pulmonologist rather than this doctor. So I think it's always good to start off with a primary. I mean, everyone should. I mean, you need to be treated for, we do a lot with preventative care and things that kind of get lost when you're just going to specialists. So I think there's a good reason to have a primary, and we're the gatekeepers. We can kind of tell you where you need to go.
When do you want to see patients too, like based off of that? At what point in the treatment do you really want to see someone, and at what point are you referring?
Yeah. Well,
I think it depends mostly on the results from the primary care. I think just to second what Dr. Janka said, I had patients with hyperthyroidism referred to me for AFib.
Yeah.
Hyperthyroidism is a condition in which the thyroid hormone is elevated. It can lead to weight loss, hair loss, arrhythmias. Basically, patients start to emaciate. And it's not a cardiac issue. It's just a condition that it's a metabolic condition that has a cardiac implication. So I have to send them to the endocrinologist.
Right.
So I think the primary care does a fundamental role at filtering those things. Wait, before you see the cardiologist. And it is true. I cannot do anything with AFib until this is controlled because it will come back. So it's a pivotal role for the primary cares.
Yeah, and I don't want to, spend too much time talking about primary care. We'll do another talk on that. But I mean, the reality is that, the specialists probably would get overwhelmed if we sent them every hypertension patient and if I sent the pain clinic every pain patient. I mean, we take care of a lot of these patients that are maybe somewhat easier to take care of. If you have someone who has difficult to control high blood pressure and you have them now on 3-4 meds, you've done a workup, and you haven't found a secondary cause, that's a good patient to refer to a cardiologist. Simple congestive heart failure, often we'll take care of that, but that's also a patient I'd like to have follow with cardiologists, especially if it's a little more refractory. Anyone who I think has underlying potential coronary artery disease, I'll send them to a cardiologist because they may require an intervention and I can't do those things. So there's patients I send because I can't do what needs to be done because it's not my field, and there are patients I send because they're complicated and I just need another set of eyes looking at them to give me some advice.
Absolutely.
So then what are the majority of the patients that you see? Like, what are they coming in with?
It's going to be tough to say the majority on that because there's a lot of overlap in the same patient.
Oh.
Many of those patients will have heart disease and at the same time will have hypertension and arrhythmia. Yeah. And they may see you in the year multiple times for one of each aspect.
Right.
So I think the vast majority will come down to coronary artery disease, hypertension, arrhythmias, heart failure. I think that's going to be the bread and butter cardiology there. Also, we cannot forget about the valvular disease, aortic stenosis, mitral regurgitation. Those things are more long-term, but usually the first visits are those. Yeah. We do have those patients that haven't seen a doctor in 20 years.
Sure.
They show up and then there's a huge murmur. You get an echo, severe aortic stenosis, so right away for surgery.
Right.
But that's on the minority.
Yeah.
Good.
And you have the patients who haven't been to a doctor in a long time and they come in, their blood pressure is 220 over 110, and they have a lot of advanced changes in their body related to damage that high blood pressure has done. I always explain it to patients, say, what does high blood pressure really do? And this is a very simplistic way to explain it, but I think it hits home. If you think about the heart as a pump, right? And it's pumping blood like this. If that blood's going somewhere and it's hitting tissue, an end organ, the kidney, the brain, the vascular system, basically the more force that you're hitting these organs with, the more chance of their being damaged.
They're getting battered.
Right. And that's why patients who have high blood pressure that's uncontrolled, they develop kidney disease, they develop vascular disease, they are at risk for stroke. It's not the high blood pressure itself that is the issue, it's the end result of it and how it affects the other tissues and organs in your body.
Yeah, especially the aneurysms.
Yes.
They come with 200 systolic, and the aorta is already 5 centimeters.
Right.
Basically looking now at controlling the blood pressure and getting a surgeon's referral.
Yeah.
So yes, that is very, very important to follow in those conditions.
But I think, you talked about the diastolic dysfunction, the heart not relaxing. That's a really important point to understand with high blood pressure for our audience, in that there are things that occur with longstanding hypertension that are really hard to reverse. Yeah. The heart is a muscle and, it will increase in size like any muscle if it has more force that it has to work against. And sometimes it's hard to reverse those changes. So, once the heart gets, we'll say stiff, that's the word we'll use, it doesn't relax. That type of heart failure, and correct me if I'm wrong, is actually very hard to deal with. It's actually easier to deal with the patients who have a decreased contractility or ability to squeeze than the ones where their hearts don't relax. And most of those patients have had hypertension as the cause.
Unfortunately, there is no medication to reverse the stiffness. Multiple things have been trialed and none have shown significant results. For the stiffness of the heart, what we say is always focus on arrhythmias, valvular disease, hypertension, medication compliance, lifestyle changes, including avoiding extra salt. Mm-hmm. Sometimes we like our salt in the meal, but we have to make changes. And just so you know, hypertension is a silent killer.
Mm-hmm.
It will give you symptoms very late in life, but you have to keep in mind that you have been developing this for at least 20 years.
Right.
So it takes that much time to actually get something significant reversed. And so it's very difficult to do.
Does someone with normal blood pressure have to worry about the salt shaker?
In my opinion, we shouldn't be eating that much salt anyway. So I always tell the patients, even if your blood pressure is low now, you are doing yourself a favor and preventing in the future other things.
Mm-hmm.
There are conditions, though, that we actually tell the patients you need to eat more salt, orthostatic hypotension and other things. But those are the minority. In reality, we should not be eating too much salt anymore.
What are some of the risk factors that you can talk about that someone will get cardiovascular disease?
Oh, well, definitely we have the traditional risk factors, and we can talk about this because the traditional ones, we have even algorithms and guidelines, but there's always the non-traditional one that gets us. So we have to make sure we always combine them. And the traditional ones are obviously smoking, hyperlipidemia, which is high cholesterol, high blood pressure. We talked about it. One of the biggest one is diabetes, obesity, renal failure, sleep apnea. Those are the things. Those are the traditional risk factors. But when you put also this one that we always don't see on the algorithms, which is family history.
Mm-hmm.
Oh.
I am a professional runner and I don't have to worry about it, but my father had a heart attack at age 50. That keeps you at a higher risk than the normal general population. We use an application called ASCVD risk score. It's from the American College of Cardiology.
Okay.
And based on that, we estimate the risk. But guess what? That risk does not include family history.
Oh.
It does include hypertension, cholesterol, smoking status, aspirin use, statin use, age, gender. But again, this is the importance of getting information from the primary care or cardiology to make sure we actually put that into context.
So what kind of family history are you worrying about? Like there's no male in my family past 70?
Well, for example, a man with age, what we define as family history, it is not precisely that your father had a heart attack at age 70. Because at age 70, that's the result of his own life.
Right.
But when you have someone dying suddenly or having a major heart attack, less than 45 in a man and less than 55 in a woman, that's a red flag right there. And I have patients that sometimes get frustrated. I say, well, I did all these things in my life and I still get a heart attack at 60.
Yeah.
Well, hadn't you done that, you would have had a heart attack at age 40.
Right. People don't
so
see
it
that
does
flip side.
pay off.
Right.
It does pay off to do the right thing when you have that family history.
You know the story of Jim Fixx, right?
No.
So Jim Fixx was a famous runner. He kind of was the start of the whole running craze way back in probably the 70s or so. His father died at I want to say 52 or 54 from a, sudden death, massive heart attack. I'm not sure they knew back then what he really died of, but it was a cardiac event. He was going to beat that. He ran every day. He wrote books on it. He became he was the man who everyone looked to as the start of the running craze, and he died at 54 while running.
No.
Yeah, of a heart attack. So, and I'm not saying that you can't impact on your family history, but family history is a very strong risk factor.
Is it I'm not sure this is a word, overcomable?
Overcomable?
So I'll be honest with you. It's difficult to fight your own genes.
Yeah.
Right. But it makes an easier battle if you don't smoke.
Yeah.
If you take care of the other things that are preventable, like diabetes, like keeping your blood pressure stable, keeping your cholesterol stable, maintaining a healthy lifestyle, you can delay some of these things. I have patients with strong family history and they outlive their parents.
Yeah, it can happen.
So we can, but unfortunately, genes is hard to beat.
Yeah, it is. On the other hand, you have people whose, family members have lived into their 90s and they do everything bad and they die much, much younger too.
I can tell you funny stories about this. When I was in training, I had a 92-year-old who smoked since World War II.
Mm-hmm.
Guy comes to the hospital with a heart attack, has a minor lesion in one of the smallest vessels in the heart, completely normal function. So we're looking at him like, man, we want to tell you to stop smoking, but at 92, we don't even know what to tell you.
Go for it.
Yeah. So you did the right thing, but please stop smoking. But just saying that you have, like you said, this variety and diversity, that the pendulum goes both ways.
Yeah,
patients that do exactly the right things and they still get heart disease and all this, that, you know what? God will let me know. And 94, 95, they do great.
I'll tell you a funny story about genetics. So I have a patient in my practice who's actually my grandmother's cousin. Okay. He's 106.
Oh my gosh.
And he's still cognitively with it. And up until a couple of years ago, he was still independent enough where he has a garage. He does automotive repair. He was like tinkering around and doing oil changes still. His son was running the garage at that point. He's going to be 107 in a couple of weeks. I just saw him in the office the other day.
That's insane.
Yeah. And in his cousin, which was my grandmother, she died at 104, but it was only because she fell and fractured her pelvis. So I hope I get those genes. I don't know if I will have those.
That pool of genes should be saved somewhere.
Yeah.
That's amazing.
Yeah, it's pretty remarkable. He has like 55 grandchildren.
Oh my God, that's like crazy.
Yeah, town.
It's pretty remarkable.
So now I'm going to be nervous if I'm listening to this podcast and I'm like in my 60s and I'm like, you're red flagging me in my life. It's like, okay, like what do I do? Like maybe I have diabetes. Maybe I'm chubby. Maybe my dad died when he was younger. Help.
So no, I think at this point what really counts is start with the primary care. Because they will start with a lot of other things that are playing a role. Like for example, if I have a patient that has, going back to the thyroid disease, their cholesterol will be all over the place. It is not necessarily a cholesterol problem. It's that your thyroid is a normal issue. Right. So it does make sense to start with your primary care where they're going to run a whole panel of things that this is well described. You check for your liver, you check for your diabetes, you check your kidneys with urine test. And once they start having abnormalities, then we'll direct where to go. Yeah. So this is why our work with the primary care is very important. If by any chance you come directly to me, we all did internal medicine. We'll start with those things, but it's better to have a primary care because they're better trained at all the things that we are not. And the same thing with us. We are training on things that they are not. So we complement rather than, the way I see the primary care field is not higher knowledge, is that we complement each other because we spend more time in certain areas. Yep. There's no way to know everything. So we have to complement.
We have to have a broad knowledge of a lot of different areas. And, specialists are more focused, but they have a more in-depth knowledge, obviously, of that area. But we work well together. I mean, we complement each other. We with our patients, it's a little bit of, we provide information and they provide information and it all works out together. But I think it's important to work together, primary care and the specialist. Hard to do without.
Now, we talked about some of the risk factors, but what's someone feeling like? What are some of the symptoms that they're getting in trouble?
If I could say something, as we were talking earlier, the things that we want to keep from this meeting is mostly do not ignore.
Yes.
Many of the symptoms in cardiology overlap with other things. I don't mean to also scare anybody to go immediately to the primary care, say, I've been feeling this and I heard somewhere that this is happening, but it is not uncommon for women to have 5 days of heartburn when they're actually having a heart attack. Mm-hmm. Or men having shortness of breath and they're putting it off. And then when they go to the hospital, the heart attack is already completed. Right. So variety of symptoms, the hallmark one is chest pain in the middle, radiated to the left arm. Sometimes it radiates to the teeth, sometimes to the ears. So that's some of the things that we need to make sure. But the hallmark is symptoms on exertion relieved by rest. Mm-hmm. Actually, the ACC defines angina as symptoms on exertion or stress relieved by rest or nitroglycerin. Mm-hmm. So if you have something like that, and what symptoms are those? Shortness of breath, chest discomfort, chest pressure, chest tightness. And for example, a bad heartburn should not make you sweat. Right. Oh. Some people with the heartburn, they start having the symptoms, the tightness, and they start sweating. That's just a massive adrenergic response that tells you that there's something serious going on. Not heartburn. It is not heartburn. That was not the chicken wing you had 2 nights ago. Right. That is not.
Right. But you're right. A lot of people think it's heartburn. They stay at home and they say, if I just go to sleep, it'll go away. And they don't wake up in the morning. Yeah. Sadly.
How did that work?
Sadly, we have those things that when they go holidays. Yeah. Holidays are very common. My family's here. Thanksgiving, come on, I'm not gonna do that to them. They go on Monday, the heart attack is infarct already.
Yeah, right. So yeah, and you made a good comment about, with women, the presentation is often very different, and that's important for the audience to know too. I think that women can present very differently. They don't always, they can present the same, but the classic kind of crushing chest pain radiating to the arm, it doesn't always occur that way.
Yeah, we have it. We have it right into the other arm, right into the back, nausea and vomiting. Because of how much discomfort they get nauseous and vomit, and that's actually why they went. They were having a heart attack.
This is kind of tough because some of the symptoms are just like so vague. Like if you get a little dizzy, if you're a little nauseous, well, that can happen.
Yeah, but fortunately, we have tools to figure it out, and that's the key to all this. It can be sorted out, and actually pretty rapidly too. But I'll let you talk about that.
No, I mean that's a great point. I mean, we have ways. As I said, is mostly education what we need. So when those people come to the hospital, we can identify them, do the proper testing, and triage them. Because acute chest pain on its own is a nightmare for ER doctors sometimes, because you have to go, remember, in the chest is not only the heart. You can have esophageal rupture, you can have a pulmonary embolism, you can have a bad pneumonia, you can have a traumatism if you fell on top of that.
Right.
Yeah.
So sometimes it could be difficult, but like Dr. Junka said, we have very delineated algorithms that can help us triage those patients and know exactly what they need. And also risk stratify them. Sometimes there was nothing, and then, hey, you can go home, follow with your doctor. But again, in that sense, people have to be educated to come in so we can help them with that.
What are your thoughts on like the apps on the phone? Like, oh, I can look at my heart and check my EKG and do all that stuff.
Well, a few apps there have FDA clearance. I have a good experience so far. I've identified a couple of patients with atrial fibrillation.
Nice.
And that, I mean, I don't want to exaggerate, but it could have saved their lives.
Nice.
I mean, it could have saved them from a stroke,
Nice.
from a massive one.
Right.
But something is that these devices are not professional devices. So they have limitations. It's a watch, so most of the time. If you don't have enough contact on the skin, the device will say, I didn't sense it. So it will say there's a irregularity.
Right.
So it shouldn't alarm the patient at, oh my God, I'm going to die soon. But it should call and alert, this keeps happening. Maybe I should talk to my doctor about it. Unfortunately, we had some patients with anxiety from this. Oh, my device is saying this. Well, relax, take a deep breath in, bring us the information. The good things about these devices now is that you can print the information.
Yeah.
Bring it to your doctor.
Right.
Look, this is what it is. And if the quality is good, we can make a diagnosis. If it is not, it will prompt other testing.
Right.
So it still helps you, but we have to make sure that we have objective professional information before we start treating the patient as such. Labeling a patient for AFib is a big deal.
Yeah.
So we have to make sure that we have trustful, objective information before we do that.
Speaking about AFib, what do people feel like if they're going into like AFib, like in and out of AFib? What will they feel like?
Maybe nothing.
Yeah.
Unfortunately, that is very true.
Yeah.
Will you feel like your heart flutters?
30% of patients don't feel the AFib. So 3 out of 10 are walking right now and they don't know they have AFib until they get a stroke or an embolic event. Yeah. Again, the importance of checking with your primary care, that yearly EKG make a difference one time.
Right.
When do you do EKGs?
I do them on anyone who has, risk factors for heart disease, or if they have hypertension. I'll do them once a year, unless there's a compelling reason, such as they come in with chest discomfort or something else going on, shortness of breath. But for my routine, health maintenance type patients, I look at their diagnoses and their risk factors and determine based on that. Because you unfortunately, a lot of this stuff you have to have a reason to do it, or the insurance doesn't cover it. But most of the time, a lot of times there is a viable reason to.
There is a few apps out there, a few devices that actually have really good quality. They can give you 6 leads. I'm gonna refrain from names for all things, but
sure.
There are devices that you can get at home, and with proper training, they provide high quality tracing, and they're not expensive. But as I said, we need to make sure that this opens the door for further investigations. It's not a final until we get a professional involved in that.
And we like the ones that are FDA approved for doing that stuff.
Ideally.
So when you Google it, you want to go buy one.
Exactly.
Do the FDA approval.
So let me ask you a question. If you look at all of the risk factors for heart disease that are out there, and some are you can impact on, some you can't impact on, like family history, you can't do much about your genetics. But if you were to put in order what is most important to least important, could you do that for our audience?
I absolutely can, and I'm gonna give you 2 that I think in particular are just deadly. One of them, we can make the effort, and another one, we can do better, but I think it requires more time. And those two are smoking.
Yes, I agree 100%.
The patient can say, "I'm sorry, I know it's hard. It's an addiction. It's a legal addiction, which is I don't understand why we still have it out there, but it's a legal addiction. But the thing is that we can make that call not to buy that cigarette.
Right.
We can make that call to say, I'm not going to buy that box. I'm sorry." Now, the other one that I would say that takes more effort is the diabetes.
Yeah.
I mean, unfortunately, if you have the genes for diabetes, we cannot blame you for that.
Right.
Right.
Not that I would blame any patients, but I'm just saying that diabetes is something that, man, if it happens, we're here to help you.
Right.
But at that point, you can make changes in your life. You can start saying, you know what? I enjoy the carbs, but this is it. And you start cutting down.
Yeah, and not only, I mean, I would have actually ranked those exactly the same. I think that smoking and diabetes are 1 and 2. And then when you put both of those together, what patients don't realize, it increases the risk of heart disease much more than each individual.
It is not direct, perfect. It's not directly proportional. It's exponential.
It is exponential.
So that's the problem. If you go into your statistics, you can tell when something is directly proportional, it just follows a straight line, but hyperbole goes up.
Yeah, so I'll say this to the audience. If you have diabetes and you're smoking, your risk of heart disease, stroke, etc., is remarkably high, much higher than each individual.
And I mean, and you can have another day. Me, I'm just a cardiologist, but neurology will tell you the same. Vascular doctors will tell you the same. We always think about heart because it's only one, but a stroke is equally, it can be detrimental to the point that you end up in a bed.
Yeah.
In a way, cardiology gives you a second chance. You can get a heart attack, you survive that, you move on. A stroke sometimes can be just debilitating and detrimental. So following your list, I would say cholesterol is another one.
Sure.
And also obesity, right? With the obesity, we can make that determination. Like, you know what? This is it. I'm going to make some changes here. We have a lot of mechanisms now. We have bariatric surgery. We have nutritional stuff. If you guys want to talk about this another day, because the problem is with insurance and coverage and all the things, but we do have mechanisms to help the patient now lose the weight. Yeah. So those are the other two now. If you're going back, as I said, I like to make 2 lists.
Right.
Things that we cannot avoid, it is what it is, and things that we can actually do something.
Right.
Unfortunately, there are patients with renal failure. They develop the renal failure for something else, and because of the metabolism, it's a deeper conversation, but they do develop a lot of calcifications.
Right.
And that's not on the patient. This is what it is. This is part of the renal failure.
Yeah, they develop a lot of vascular disease.
Those valves, they become basically rocks, and that's not their fault.
No.
It happens. Another big one that we should talk, and I think the audience should know this, is breast cancer with radiation therapy.
Yes.
It's something that I thank God that I remembered in this conversation, because if you receive radiation therapy at any point in your life in your left breast, please see a cardiologist at some point. 20 years after, you can develop heart disease, accelerated heart disease, pericarditis, valve disease, and muscular stiffness.
Why?
Because radiation in the past was not directed towards the breast. Yeah. They would just radiate the whole thing.
It wasn't as focused. And, it unfortunately, it doesn't just damage the tumor. It damages surrounding tissues when it's not focused as well. We can focus it a lot better now.
Yes.
Okay. But that back then it wasn't.
So what kind of time frame are you talking about?
Well, anybody who got radiation therapy before 2000 should be looking into, I heard this on the news. Yeah. What should I do? Because their tissue gets more calcified and brittle.
I'm glad you mentioned that.
Well, especially for women, because breast cancer is a terrible disease that haunts you.
Right.
Even 20 years after.
Right. We don't need to be dealing with that too.
I mean, imagine a poor woman, 5 years in recovery, all then, and then boom, now have this. Yeah. So it is important to follow on that. So going back on those, you have a sleep apnea.
Yes.
As you know, this increases the adrenaline overnight. That also is a risk factor for heart disease. And I think that would be the major ones, actually.
How about stress? We're in very stressful fields.
It's a fantastic question. The problem with the stress, even though it is defined in the ACC, the problem is that we don't have an objective measurement for stress. What is stressful for you may not be stressful for me, and vice versa. But a stress can lead to a lot of conditions, including, we have a few artists dying from this, stress-induced cardiomyopathies, broken heart syndromes. Yeah. These things are real.
Yeah, I've seen that.
Although this is not associated to blockages, it can happen. So, but yes, the stress can be detrimental, especially for those AFib patients. adrenergic all the time. They're very difficult to control AFib. It plays a role. Hypertension. These patients become very anxious, and it's basically a vicious cycle. High blood pressure, anxiety, high blood pressure, anxiety. It just keeps looping in there.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
Can I ask you a general question? You know, when some people are diagnosed with, like you talked about, diabetes or cholesterol, and you're like, oh, we should go on medication, and they're like, oh no, I'll do it myself, I'll lose weight, blah blah blah. Like, how long are you giving them to? Okay.
So with diabetes, for example, I'll tell you how I approach it, and I think this is pretty standard. If the hemoglobin A1C is not outrageously high, I'd like to give patients a chance to lose weight and exercise.
What numbers are you looking at?
So, anyone who is over, I'd say, and we'll talk about age groups, okay? So if they're in a nursing home, I'm much more liberal with their hemoglobin A1C, and that's the standard. You can be 8. Everyone else who's walking and talking and out in the community and healthy and not 85 years old, I want it under 7. But if they're older, I don't care as much, because it's more detrimental to tightly control them. They'll become hypoglycemic, fall, break a hip, etc. So I'm happy with 8. If someone came into my office and they had a hemoglobin A1C of 10, and they were a fairly healthy person, otherwise functional, not a nursing home patient or an end of life patient, I would actually put them on a medication. Because I know that with diet and exercise, it would be very difficult to get that down in a time frame that would make sense. If they came in and they were 8, and let's say the goal is less than 7, I'll give them a few months. I'll let them work on that.
Fair enough.
So, and I think that's pretty standard, quite honestly. That's how most people approach it. With hypertension, if it's early hypertension and, they have risk factors they can modify, and please jump in if you disagree, I'll have them work on lifestyle modification, and I'll have them back in a period
There's nothing
of
to
time.
disagree with that, Dr. Jenks. So what I do, like he says, is that we give them 3 to 6 months.
Okay.
One of the things that I also want to tell the audience is that if you're young, 40, 50, and you have high blood pressure, your goal should be to get off the medication.
Okay.
So if you're 70, 80, your goal should be to keep the risk low. But at 50 years old, if you have obesity, the goal should be, I'm going to put you on this medication while you lose the weight, and we can titrate down to the minimum necessary. I'm not a pill guy, even though I'm in cardiology, I'm not a pill guy. I like to keep my patients to the minimum that they need, because then you have encountered side effects, cost, financial burden, all these things are real. So losing weight is free.
Right.
It's actually cheap if you think about it, right? So my point is that this requires effort and discipline. That is the only problem. But the idea for me is to keep the minimum required. And if we can get off, I have patients that they're motivated for blood pressure meds. They either go for surgery or they lose weight on their own down to 1.
Nice.
That's a success to me.
Yeah,
we went from 4 pills to 1 tablet.
Of course.
Less side effects, affordable. They feel better.
Right.
So I don't see why we shouldn't push for more lifestyle changes rather than pills, see you later. I think that's a good approach.
And I have had some patients who've have done major lifestyle changes, and they've corrected all of these metabolic abnormalities, and that does happen. But I think to speak to what you're saying is you have to. Every patient is different, right? It can't be boilerplate. It can't be the same approach for every patient. You have to tailor it to who that patient is, what is their general health? What are the comorbidities or medical problems that they have? What is their age? What is the risk of complication with the treatment? All of that.
Especially, not to be, I want also to be unfair to people that cannot exercise anymore.
Right.
Hip fractures, back pain. So this is the realities that we have to face.
Yes.
What I said earlier is just someone, I'm 41. So someone like me, hypertensive, why would I just stick with a pill?
Right.
Yeah, if you could get off it, exactly.
I can get off it. But again, if I had major surgery, I cannot exercise, well, then that's life, and we're here to help you.
Yeah.
Right.
And I've had younger people who've been on it for a period of time, and they've gotten off it, and that does happen. I think it's harder when you're older. It's harder when you've had high blood pressure for a long time, and maybe it has some more permanent effects.
Yeah.
And then as you get older, actually in the older population, I try to get patients off medications if I can, because the side effects are
Right.
greater.
To your point, what you said earlier,
Yeah.
the JNC8 was very clear that not to be aggressive in the late stages in life.
Yeah.
So
Absolutely.
before we talk about some of the diagnostic testing that you do, I want to just go back to the heart attack. Is there a common time of day, like a more common time of day that people have heart attacks?
So somebody looked at that in some trials, and apparently there is an association with cortisol rising.
Right.
Oh.
Early
And
morning.
so early morning is more common, but to be honest, I was a little bit biased because many of that population were cleaning snow at that time in the morning.
Okay.
So it also
Interesting.
depends on
What you doing?
what you're doing. So it's the amount of effort you put in the morning, but there is an association of rising cortisol early morning and more heart attacks.
Oh.
But it's also had to do a lot with people waking during the day and doing things.
So cortisol is a stress hormone, so it kind of it increases in the morning to get us ready for the day and the stresses that the day will bring on, and that's why it's higher in the early morning before we, right around the time we wake up. Or
My
before we
husband
wake
should
up.
be extra nice to me in the morning to make me So last question on the heart attack stuff. They used to recommend chewing an aspirin. Is that still, like, if you're feeling that crushing pain?
Not
what are you
really.
doing?
We have data now suggesting that we should not be doing that anymore.
Oh, okay.
So before there was this concept of if you're above 50, you have higher risk, take an aspirin every day. Well, not really. You increase your risk of bleeding without any extra benefit.
Okay.
So this should be tailored towards your risk. Remember what I said earlier in the conversation, this ASCVD risk score? So we calculate that, and if it's high, then that will warrant an aspirin. But if it's low, you don't need that. So that concept of like, I'm going to take an aspirin every day should not be.
Okay.
Right. It's interesting when that started to get out in the, the news about aspirin not being as good as we formerly thought it was for primary prevention of heart disease. I had all of these patients who needed to be on aspirin because they had some vascular disease or coronary, and they stopped it because they didn't understand the difference between what
Exactly.
they were talking about in that particular study. Because it really was, in the media didn't do a great job discussing it.
So there is a difference between primary prevention
Okay.
and secondary prevention. And what Dr. Jonkes is referring is that if you have a stent already, that's secondary prevention. We never mentioned that. We said the guy that is healthy, 50 years old, guy or woman, that is healthy, 50 years old, take an aspirin. No. But if you have evidence of heart disease, or you have a stent, or you have interventions and you have proven disease, please do not stop it
Right.
without talking to your doctors
That's
about
a really
it.
important point.
So it's primary and secondary prevention. One is I want to help you prevent a heart attack or a major cardiovascular event. And the second one is you already had it, man. We have to protect you from a second one.
Right.
So that's the thing.
All right. So now let's get into some of the diagnostic tests that you do. Do you want to talk
Yeah,
about?
sure. So multiple testing depending on what the condition is, right? So if you have, going back to the analogy of the house, so we
Yes.
have ultrasounds of the heart. They can check valves, chambers. If you have palpitations, you can get monitors for arrhythmias.
Okay.
If you have problem with the plumbing, we get a stress test. and sometimes we also have cardiac CTAs where we can actually see the vessels in 3D to see if there's actually a real blockage.
Right. So that's a CAT scan angiogram, CT angiogram.
So
just for our
unfortunately, stress is sometimes this is not black and white.
audience.
A lot are coming to clinical intuition, and a lot are coming to what the test will show you. So I think there's a junket. This is why we will never be replaced by computers, right?
Probably not. I hope not. I hope AI doesn't take
I don't
over.
think AI is so narrow now. There's no way to think outside the box. I had patients with normal stress tests that I sent for cath and then open heart surgery.
Oh,
And I had the other way around.
Yeah.
Bad stress tests, you send them for cath, there was nothing.
Yeah, you have to use your, a lot of medicine is beyond, you have to look at the testing, of course, but it's putting everything together. And like sometimes, as you mentioned, you do these tests and you do a stress test and it's negative and you're like, there's something about this that isn't right.
yeah. Cardiac can be tricky. Huh?
And you end up doing a cath and they have severe 3-vessel disease. And I think in that case, it's because they have disease everywhere. The blood flow wasn't diminished in one particular area, and it's
They're
a false
multi-
negative.
Exactly, a multiple mechanism, right? The own bypasses that you create called collaterals. So it is, the heart is smart. If there's a blockage in a certain area, it will try to create little channels around it see it as if 24 North is crowded, like usual, right? So if you go over the sides with the smaller streets, you still get a Boston, right?
Yeah.
But that's what collaterals are.
That's a great way to
If
describe
the
it.
major avenue is blocked, the heart will find its way. But sometimes even those collaterals are not enough.
Right.
So
And it
that's
takes time.
And it takes time.
So if you have an abrupt occlusion, if a plaque ruptures and you block an artery, well, you're in trouble.
Yeah, that's more in the acute setting.
Right,
That's
in
more
the acute
hospital.
setting. Yeah.
In the stress test part, we assume that, this is something more stable.
Right.
But in this, we do have ways, precisely because of tests, as I said, if something the audience will keep is no testing in medicine is 100%. We try to make it as close to possible, but a stress test, just so you understand something, a normal stress test, you know what that means? It means that you don't have critical occlusions. That we have 98% chance of not missing a critical occlusion. That means you still have a 2% chance of missing it. And critical occlusion is defined by more than 70.
Right.
So you can still have a nice 50% there, and you have your stress test a year ago that was normal, and it can be normal. So this is why I don't want patients to think, oh, my stress test was normal. Why did I have this?
What happened?
It wasn't testing for that.
Yeah.
So this
Is there
still
a
a
simple
chance.
blood test?
Yes, there is. So cholesterol profiles are very important.
Okay.
And we based our treatment mostly on LDL cholesterol, make sure that it's low depending on the risk. And it also protein C reactive, high sensitive. So there's new data that is less than 1 is normal, 1 to 3 is intermediate risk, and more than 3 is high risk. So you get that into context. There's also a calcium score based on a CT scan technology to see how much calcium you have in your heart. That can also give us an idea. In the past, used to do, I don't know if you remember that they used to do intimal thickness size
On carotid.
in the carotid.
Yep, I do.
And it also have the aortic aneurysms, also part of the score. So you can have multiple things. And in patients with family history, a lipid profile is not enough. You got to go deeper. There's something called apolipoprotein A and B, and you look for those as well. And also genetics. I think it's important to get these things because if you have something genetic, you want your kids to know that.
Right.
I mean, so I think it is important to check when you have someone with high cholesterol out of nowhere. It is important to pass on that information to your kids.
Yeah, I agree. And I think one thing to keep in mind for the audience, and I'm just going back to my roots as kind of a generalist, is that it is a whole system. So the cardiovascular system is a system. So, if you're found that you have peripheral vascular disease or carotid artery disease, you probably have coronary artery disease too. It's all the same system, basically.
That has been tested, Dr. Youngest. 30% of patients with vascular disease will have heart disease.
Right.
It's a vessel.
It's a
It's a smaller vessel, like actually worse. If you have something big that is occluded, the small one, believe me, is going to be occluded too.
Right.
As I'm sitting here listening to this discussion and being part of this discussion, I guess, going to your doctor on a regular basis is just super important. And having those conversations and asking the right questions, I guess, is also super important.
I think we do a lot of things on a yearly basis. Going to your doctor once a year should not be a problem.
Yeah.
In my country, they used to joke that if you go to the doctor, to the bank, and the car shop in one day, that's a problem. Your day is gone. It's over.
You're done.
Right.
But if you can at least spend one afternoon,
Yeah.
just you get it checked. Especially after 50.
Right. I think once a year for everyone, but particularly as you get older, it's really crucial. And then as you develop problems, you of course need to be seen more frequently, but just for screening and preventative care, absolutely once a year. We pick up a lot. We really do.
You send me a lot.
Yeah. Yeah. I mean, you see people, they come in, they feel fine, and you check their pulse and it's irregular. You do an EKG, they have AFib, they didn't even know they had it. Or, you're taking their history and by the way, I'm a little short of breath when I walk now. And then it leads to a workup and you find abnormalities. So a lot can come out with these so-called preventative maintenance, health maintenance visits, annual visits.
Now, you had touched on two things when we were talking before the podcast started. You were talking about the importance of education. If you could kind of just circle back to that.
Yeah, we were just talking about the maternity things and how certain populations don't have access to resources, but it's not because the resources are not there. It's because they just don't know the resources are there. And in a world in which, unfortunately, finances and economics rule many of the things that we do in life, we were just talking about how nice would it be that in between commercials, between IHOP or whatever, You get a commercial about if you have heart disease, these are the resources that are available in your community.
Right.
Or if you have questions about your overall health, these are the resources so people can at least look into this.
Mm-hmm.
And unfortunately, people that insurance companies don't cover or they don't have resources, but there are a lot of things that are available for free.
There are.
And they just don't know exist. And it gets lost every year. So I think, in my opinion, education plus showing them how to do it, and also the initiation from the patient. Like, okay, I want to do that. It's a 50-50 thing, right? Resources are here, information is here, and the patient wants. I think that will make a big difference.
Together.
Yeah.
Of course.
I mean, there's a lot out there that I think patients don't realize, like you say, is available, and it doesn't cost anything. I'll give you an example. I'm not going to make this an advertisement, but if you're a primary care patient and you're on the portal, so that your health record basically has in it a problem list, and your doctor can send information to you through the portal, through another program that's associated with the portal, that without any diagnosis you may have. So you have hypertension, he can send you information on hypertension, how you control it, what you can do for lifestyle, whatever it may be. But the point being that a lot of these resources are there. They don't cost anything. I try to get patients on the portal and they never want to go on it. But the ones who do go on it and use these resources, they're amazed that they're there and they don't cost anything.
And then just to be sure, did you know that we have pharmacies that will charge you $4 a month for medication?
No. Can we talk about that?
Yes, there are pharmacies here. Again, we're going to stick no advertisement, but there are programs in Massachusetts, all medications that are equally effective than the brand. That are only $4 to $10 a month.
Yeah.
So now your blood pressure medication costs less than a Cheetos.
Right.
So how does someone find out about that?
Exactly the point. If you go see your doctor and, hey, you have high blood pressure, I don't have money. Well, we start with the 6 months of non-pharmacological therapy, weight loss, diet control. Doesn't work? Hey, these are the pharmacies. I have a list in my office of all these pharmacies. And unfortunately, well, I'm from Dominican Republic, so unfortunately, many of my people from Dominican Republic or Puerto Rico, they may just have come into the country. They don't have the resources. And I help them out. Look, this is available for you. Mm-hmm. They get all their medications for less than $20.
Yeah. I mean, there's a lot out there. I mean, GoodRx is a good option. I use that with my patients all the time. I don't mind mentioning the name because I think it's so helpful to patients.
Well, if that's Target has a program.
Yeah,
Walmart
has a great program.
It's a lot. I'm telling you, a ton of medication.
They have a list of $4 meds, and a lot of them are medications that we use very commonly. Now, you can't find everything, obviously, on the list, but
yes, but a lot of things is out there that you can actually treat yourself at the same time as you take care of all the things. Yeah. In a very cheap way.
There are a lot of patients who they underdose because their meds are so expensive. They'll take it every other day or they'll take a half a pill a day. That's actually very common. And then we see patients who have complications because of that. But there are these resources available where a lot of these medications are really inexpensive. Now, the newer meds that you see advertised during the Super Bowl and that, they're not going to be on this list.
Exactly.
Okay. But there are tried and true meds for hypertension, for diabetes that are out there that are on these lists that you can tap into.
And then if something happens with they're changing coverage and all of a sudden their medication's more expensive, 1 month than it was last month, they can always contact you and you can look at alternative medications too.
We do that all the time in primary care. I mean, probably 20 times a day. This med is no longer on a formulary, or the insurance isn't covering this anymore, and we have to find a substitute. I do it all day long.
And also, many of these major companies, they also have assistant programs.
Right.
And based on your income, and they subsidize a lot of it.
Nice.
I have patients with brand names, medication brand new, very expensive out of pocket, but because of their assistant programs, they don't pay much.
Right.
Or don't pay at all.
Yeah.
So again, that's limited, but you have to look for it.
Right.
Nice.
Right. There's a lot out there that's free or inexpensive. So there's a lot you can do if money becomes the factor that prevents you from prevents you from getting good health care. There are ways to overcome that.
Okay.
Yeah. So
absolutely.
Yeah. This has been a great conversation.
I
can't believe we've been actually talking almost an hour now. Do you believe that? I'm always amazed when I look how the time goes by,
yes,
how quickly it goes by. But at this point, I'd like to ask you, is there one message you want to leave the audience, and maybe a story of someone you've impacted on that you might be really
I think
interested
the most important message, please do not ignore.
Mm-hmm.
I would never tell a civil contractor how to build a house.
Mm-hmm.
I would never tell a lawyer how to do their practice. So that means I don't know anything how they do. So if they start noticing things in their bodies, don't diagnose yourself.
Right.
Get help. And once you get a diagnosis, you'll feel better and you'll know how to treat it.
Right.
So do not ignore, because those 5 days with heartburn or chest pain may cost you months in a hospital when it could have been taken care of. It doesn't mean that you're checking out. It just doesn't feel right.
Yeah, you want to get there before the heart's damaged, right?
Time is muscle. That's what we say. Time is muscle.
Minutes equals myocardium, as they say, right?
So that's what we used to say. Time is muscle.
Yeah, so true. And how do people reach you other than through their primary care doctor?
Well, I am at Primary Care Cardiology here in Pleasant Street, so it's going to be easy. It's the only one with Latin American name. It's the one with the longest name, that's me.
Okay.
But we do have a great practice there, so wherever you go, I think it's going to be the same care. We're very happy to see anybody who needs help over there.
Yeah, that's great. That's excellent. Anything else you want to ask about before we close, Nancy?
I am very good. I almost feel like we'll need to do a follow-up at some point,
Yeah,
so he
we
can get
may.
more into like nitty-gritty stuff.
I'm happy to help out in all the topics too. This is
Yeah.
preventive.
Yeah.
We can talk about valvular disease is also a big one
Yeah.
too.
This was a good start. I'm sure we'll have you
Absolutely.
back at some point. There's
Maybe
so
by
much
that
we can
time
delve
the
into
humidity will be better and I don't have to deal with this.
with the mask. Yeah.
Very
Well,
good. Thank you so much.
Yes, thank you so much, Dr.
My
Mendieta. I
pleasure.
really appreciate it. You did a great job, and it was really, really informative.
No, my
our
pleasure.
audience,
Happy to
I'm
help
sure.
out anytime. If anybody, as I said, if we can save a life out of this is just an hour.
Right.
This is perfect.
Absolutely. So I want to thank all of you out there for listening to our show. And if you'd like to become a sponsor, because we do rely on our sponsors, please contact us at 774-319-4230. Special thanks to Ron Gamache, my good friend, who does our intro music, and also to the PC Institute for producing the show. And finally, Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. We are appreciative. They're our sponsor. We couldn't do this without them. Thanks, everyone, and have a great day, and we'll see you again soon.
Thank you.